Well, good evening, everyone. Thank you for joining us for tonight's educational webinar on hip and knee replacement. Tonight's speaker is Dr. Mark Gittins, OrthoNeuro Orthopedic Surgeon. Dr. Gittins is a board-certified orthopedic surgeon specializing in sports medicine and arthritis with extensive experience in outpatient joint reconstruction, including robotic-assisted knee joint replacement and direct anterior hip replacement. Please type your questions in the Q&A box below, and Dr. Gittins will answer those questions following his presentation. And now I will turn it over to you, Dr. Gittins.
Great. Thank you, Renee. Again, my name is Mark Gittins. I'm a hip and knee surgeon. I'm trying to watch here on the side to see people are still signing in, so it probably behooves us to wait just a minute or two, just so we don't have to answer the question that I just said something about. So, but please feel free to use the chat box. I'll hopefully be able, if I do my job reasonably well, be able to answer most of your questions just through the talk as we kind of go through new things. I won't be able to answer everything. Again, certain things that pertain just to you, you're going to need to consult and see your surgeon and have a full workup. But I'll go through some general principles of how things are done and current concepts of where things are going with hip and knee at this point. So that being said, I'm going to go ahead and start here. Hopefully everyone can see that well, but a lot of this has to do about your recovery, your confidence. It's really your knee and hip. People ask me oftentimes, it's like, should I have surgery? Well, it really depends to you. If you meet the criterion that we have, then it really is your choice. If you're losing quality of life, you're losing steps, you can't walk as far or as fast, you can't keep up with people, then I think you get things done at that point. But it's really driven by you. I don't tell people they have to have surgery. It really is. If you qualify for surgery with certain things, and I kind of go over the comorbidities that we need to keep under control that would disqualify you from surgery. But if you have enough arthritis, and we see that on x-ray, and you've been through the appropriate conservative treatments, it really is your knee, it's your hip, and we proceed how you want to go. But we'll talk about arthroplasty, what's new, what I'm kind of seeing, some current things here in the last year or so. This is me again. I'm the hip and knee surgeon. I'm pretty much based in New Albany, where I do almost all my works, a little bit out east in Pickerington some days. I want to talk about medications to start off with. So there's been a fair amount of research, and we've learned a lot about medications. And one of the things that we learned is that opioids are bad. You've been hearing that probably on the news, but we know in hip and knee arthroplasty, the more pain medicine you take, and again, if you're taking it before surgery, you should probably stop because we know those results are bad. So people going into surgery that have been on opioids or still taking them, you should be off. After surgery, the longer you take opioids, the worse you're going to be. And so we really need to get people off the pain medicines. And so how have we figured out a way to do that? And there are numerous studies that show that you have more complications and frankly, a worse result if you go to the archaic, the old-fashioned way of like, oh, I got to have pain medicine. Like, maybe not. So the medicines that we routinely use, and people will ask about them, we'll put people on aspirin. And even people, quote unquote, that are allergic to aspirin are able to take this regimen. We've done numerous studies, and people that are allergic can still get through this. We use a baby aspirin, something for a 2-year-old, but it gets us through what we need to stop the platelet aggravation, and then we really are able to diminish any chance of blood clots. So that's one of the reasons we'll use aspirin. So that's one of the medicines we use. The other medicine we use is something we call TXA, transischemic acid. This medicine is somewhat new in the joint world. We've been using it for years, but it's now becoming prominent. It is pretty much eliminated in primary surgery the chance of blood transfusion. You used to hear about transfusions all the time. But once this medicine came on board, we really have seen basically no transfusions. Recently, in the last year and a half, we've also seen that, especially in knee arthroplasty, knee replacement surgery, if you use this medicine post-operatively, so not only during the surgery period, but if you take it after surgery, that people have better range of motion. And so that's one of the things that we do routinely, is that we give this medicine post-operatively, especially in knees, to help with the range of motion. We give it IV routinely during surgery to help with bleeding. And again, that pretty much eliminates the chance of transfusion, but we've noticed increased range of motion if you give it post-operatively. Steroids, we use steroids quite a bit. We found out that this does really well with people, so we give that to them during surgery. And then we give them the steroids after surgery in a descending dose. So you're taking 5 pills one day, 4 the next, 3, 2, 1. So you're done. But the steroids have shown decrease the inflammation. Even on people that are diabetic, they have to be careful with steroids because they seem to do better, and there's no increased chance of infection. So the steroids have been a big additive thing and decrease the amount of pain and inflammation, and therefore we have better range of motion and better outcomes. If we do use pain medicine in my practice, we'll use some oxycodone, but we use that with hydroxyzine. And we use these two medicines together. My pain bottles often say for itch, because sometimes these opioids will have a histamine response and people will itch. But what the real purpose is, if you look at the pharmacokinetics and how these medicines work, if you use these two medicines together, the second medicine, the itch medicine, the hydroxyzine or Vistaril is what it's called, will make the opioid last longer and it makes it work better. And so that's a way that we're able to get people going through their motion, getting their range of motion, their walking and their ambulation better without medicines. Again, the concept is the longer you're on opioids, the worse you're going to be. So if I'm using less and they're lasting longer, then we can get to Tylenol and Advil as quick as we can. We also use a COX-2 inhibitor, something like Celebrex or something like that. We use that. That has helped some of the inflammatory response as well. So we'll do that prior to surgery and then a bit afterwards. Again, that seems to have better outcomes, again, with less pain and less of a spike after pain. The anesthesia that goes with these surgeries is pretty complex. It's not just put you to sleep and wake you up. It's a lot more complex. We do 5 different things. These are just the medicines that we do to kind of help you afterwards to get you going. And then the last thing is a medicine, we'll call it hydration. In my world, when I'm doing these, my instructions to anesthesia is that we need 2 liters. I mean, that's a lot of fluid. They have to have 2 liters in through the IV before we come out of the OR. So we're really hydrating you in surgery, because if you think about it, you don't drink much the night before, don't eat much before, so you are a little bit dehydrated. But the real reason in some of the studies is that if you are hydrated, even 2 years after surgery. So if you think you had surgery today, that would be what, 2027. If you do what I'm saying, the studies will say that that your pain will be less and your outcome will be better and your range of motion will be better. The biggest thing is to try to get people to understand what hydration is. Oftentimes they say, well, I drink a lot. And I don't really care how much you drink. I care what your urine looks like. That's really the outcome of how hydrated you are, is what your urine looks like. So if your urine has color, yellow, light yellow, lemonade yellow, dark yellow, golden yellow, then you're not hydrated enough to come out of these surgeries. So we really strive to, whatever you drink, Kool-Aid, Gatorade, water, tea, I don't care, to keep your urine where it's just perfectly clear. Basically, you don't even have to flush the commode because it's so clear. So the studies have shown if you do that 2 years from now, you'll have the better results. So those are the things that we've seen, that actually hydration is better than opioids. And so that's what we really try to do, is do as much as we can with drinking and then ambulation. So that's just some of the pills that we use to start out with and how we use them. We've been real fortunate that seems to be working quite well and accomplish some of the goals that we've wanted, to keep our patients comfortable, get them moving quicker. Because, these are basically outpatient surgeries now, right? So that means you're going to come in, have the surgery, and go home the same day, unless there's extenuating circumstances. But the longer you stay in a hospital, the worse you're going to be. Certainly, the longer you go to a nursing home, the worse you're going to be. The idea is come in, get done, don't make this a big deal, and get back to your lifestyle as quick as you can. So the studies are really pointing that that's a better situation than the old ways of staying in the hospital, staying overnight, going to nursing homes, those all seem to do not so good. So I'm going to show you some of the new stuff that we're working on. Again, you know, osteoarthritis is the biggest thing. There's other types of arthritis, the more psoriatic arthritis, rheumatoid arthritis, but osteoarthritis, good old-fashioned wear and tear, is like the #1 cause of arthritis that we see. And, you know, it really affects about half of Americans in some way or fashion. So it's very prominent in our society, but, you know, people become disabled, they have pain, they are stiff, they swell. You know, they may have been through conservative therapies, like I said, such as physical therapy, medications, hydrotherapy, physical therapy, and nothing really works. Well, then they may be a candidate for some form of arthroplasty, whether it's partial or total at that point. But you just have to figure out what your x-rays look like and what you have. But you don't have to live in pain. Things have really changed. And you're not too old. I've operated people in their hundreds. I've operated people in their teens. So you're not too young. You're not too old. You just have to look at what your pain is and what your x-rays and scans look like for your age and what's going on. It's a common way with arthroplasties. This is what it looks now. It's a lot simpler than it is. We don't remove very much bone. It's usually 4 to 8 millimeters of bone. We're really just working on what you've lost. So it's really not replacing the bone. It's replacing the space that you had when you became bone on bone. So it's not linear like it used to be. So we're pretty slick with the techniques now and with the anesthesia. Therefore, you're able to go home so quickly. Robotics is something that's come on. We've done quite a bit of it. We were some of the original researchers on this. You have to be careful that you're not doing something just because it's new. You got to look at the data out there. Oftentimes something's new. You hear about stuff on TV or see commercials. It's really marketing. So you have to say, am I really getting data or am I getting the marketing? And so be careful on what you're looking at that, because not everything is what it's cracked up. But certain things that you can see with robotics is that you're much more accurate. You start cutting within 0.5 millimeters. Patient outcomes, on totals, it's still a little bit up in the air. Certainly on the uni compartmental, we're seeing people with high volume seem to do better with that. Recovery time is probably within a day or so of each other. Soft tissue, you don't have to do as much soft tissue balancing and stripping. Certainly blood loss is down now because of this, but I think it may be because of the anesthesia and that transischemic acid. If we're able to do these quickly, infections down. And we do think that this is going to be the sign of the future, especially with the younger generation surgeons. They really seem to be embracing the technology. And surgical consistency is a big thing. If you're able to do one, then you're able to do 2, 3, 4, 5, and they basically can turn out the same way. So you don't have as many outliers. I'm going to talk a little bit about the T-Mini robot. That's the one we're doing most of our research now, although we've got thousands of cases with other types of robots that we've already done, but they've worked with us on this. The company's based in Fremont, California, so they've got a lot of technological nerds out there in the Bay Area. So lots of people that are very much into computers. We're able to form these 3D models after we get a CAT scan. We're able to plan the surgery before the patient's even in surgery. We know exactly how much we're going to cut, remove, how we're going to balance it, what the alignment's going to be. We know all that before and the skin incision's ever made. We're able to translate that data into a surgery, outpatient, and then they're home by lunchtime. So we did a number of these today, and everybody was home very quickly. So this is how we kind of do it. Then with the CAT scan, I'm going to show you a quick video just so you can kind of get a little grasp. This is somewhat new, but it's pretty interesting. This is the company that really started with RoboDoc. If you remember that, oh my gosh, that was probably in the 80s, early 90s. It was called RoboDoc out on the West Coast. But this has evolved, and now we have this miniature version. So all that technology has come down, just like your old cell phones. Everything's gotten smaller. Your old computers, everything's gotten smaller. So you can see how this robot works. I'll give you a little view of this.
Our knees, the biggest joint in the body, they keep us moving. With every step, every swing, with every walk, whatever this is, in our own unique way. It's all about keeping us moving. But over time, the cartilage and bone can break down, causing pain, stiffness, inflammation, and swelling to set in. This damage to your joint is commonly known as osteoarthritis, which affects more than 32 million people in the United States alone. It is one of the leading causes of disability, affecting more than 1 in 7 adults. It's painful. It can stop you from staying active. It can keep you from doing the things you love. When a knee is severely affected by arthritis, a total knee replacement might be recommended as a course of treatment. A total knee replacement is an operation which removes the damaged cartilage and bone from the knee and replaces it with an implant to restore function of the knee. One of the more amazing and modern developments in knee surgery has been Think Surgical's T-Mini miniature robotic system. The T-Mini system includes a handheld, wireless robot handpiece to be used by surgeons to help accurately, precisely place implant components. Accuracy and precision can affect how well and how swiftly you recover. T-Mini uses a detailed preoperative surgical plan based on CT scans of your knee, and throughout your procedure, T-Mini operates under the complete control of your surgeon. The state-of-the-art planning technology is always tailored to your needs, and these sophisticated robotic and planning platforms help support you at every stage. Generally, robotic systems restrict implant options, limiting your surgeon's ability to customize a procedure to your specific needs. Until now, the advanced T-Mini miniature robotic system is powered with ID Hub. A growing proprietary databank of partner implants offers freedom for your surgeon to choose an implant based on your unique and individual needs. Ask your doctor about a total knee replacement procedure with the T-Mini miniature robotic system. It's all about getting back to what you love, because above all, it is all about you.
So kind of interesting, gives you an idea of how some of this works. It's a little more complicated than their video shows, but it is interesting. So to get these, struggling here. Whoops, that wasn't good. Oh, there was an error. No worries, we only had one more slide anyway. To get to these, hopefully we're back to normal here. To get to these procedures, you really need to be optimized. And so, you know, we had the insurance company looking over our shoulders all the time. And to proceed with surgery, there are certain things that you have to have accomplished. And so you have to have had the disease more than a week. You know, it has to be long-standing arthritis. They're going to want to see conservative care. So have you been through physical therapy? Have you tried medications? And usually they want at least two. So I tried Tylenol, I tried aspirin, I tried Advil, I tried Aspercreme, I tried, you know, any of those. Oftentimes they'll want physical therapy at least attempted, and that can be at home. And sometimes you can stop that if you become more painful. So that's what insurance companies is going to want to see. Other things that prohibit people from going to surgery are steroid shots. So if you have corticosteroid shots, that's kind of a do not go. Other things, if you're a diabetic, your hemoglobin A1C needs to be below 7. So that's going to be one of the yes or no questions that we can answer. Tobacco's a no. And then history of infection is, you need to talk to your surgeon about that. History of previous surgeries and multiple surgeries, that's a complicating factor. So each surgery that you may have had before is going to be different. So you need to look at that, see if you have retained hardware. Having retained hardware can complicate things, and you may need more than one surgery to have that removed. Obesity, obviously in Ohio, we have one of the higher rates of obesity compared to other states. So we use a measurement called BMI, body mass index, and so that way everybody is on the same page. We want everyone at 40 or below on the BMI scale, and so that's what we look for. Studies show that some of the new GLP medications, the Ozempics and such type medicines that you may hear about, they're really making an impact on people getting there that are having weight challenges, getting down to an acceptable rate. So they minimize their complications. So people that have these comorbidities, I was saying, they really have higher complications. So you really need to do everything you can before surgery so that surgery and the recovery is pretty smooth. Lung disease is another thing. So being on oxygen, it's not a contraindication, but it certainly makes things worse if you're on 2 liters or more. Sleep apnea can be something, especially if your settings are above 13. We just have to do certain things and watch you a little bit more on that type of thing. So that's what we kind of see in the world of arthroplasty right now. So kind of some new stuff, hopefully not earth-shattering, but hopefully eye-opening for you, that you realize things aren't like they were in the past. And we have some new techniques that may be out there. So with that, I'll open it up to questions if people have questions, and we'll try to go from there.
Dr. Gittins, we have a question that came in. What is better, anterior hip replacement or posterior?
That's a great question. Whichever one your surgeon does best. So there are numerous studies on this, and I don't think one is better than the other. I think whatever your surgeon does best is the better. Each approach has an advantage and it has a disadvantage. My caution to you, don't get caught up in marketing, because some people will say, oh, I do this, and so you should pick me because I do it this way. And the studies have really shown that those results are really the same. And you got to think, okay, I'm not thinking just this week or 6 weeks. I'm going to think 20 years from now, 25 years from now, 30 years from now. Is my approach, is my outcome better with the approach that's chosen? It really hasn't shown that. So be on guard that you're not getting caught up with marketing. I can do it any of the ways. I do what I think is best for a number of reasons, but each approach has a pro and a con. And so you know, they'll say, oh, I do this and this, but what about the cons of each approach too? So you got to look at what you're dealing with on that. So again, I think really the most honest answer there is you should do whatever your surgeon does best. Don't ask them to do something they're not as familiar with. Do what they do every day. And my caution would be, just be comfortable with your surgeon. Don't pick an approach, pick a surgeon. The approaches really are the same, but you need to feel comfortable with your surgeon.
Great. What type of materials are used for replacement?
So it's a good question, and it can get a little bit complicated. Most of the materials, and I'll talk about hips, that's probably the easiest ones right now to do, but most of them are titanium based. And so it's a titanium based metal. And then the articulating surface for most people anymore is ceramic. And then it articulates into a plastic we'll call high density polyethylene. So that's really what the material is. So very well tolerated. The bone really likes titanium, and so a lot of these grow right into the bone. They all become one very quickly. So that's the beauty of using the titanium. It's light, it's strong. Obviously, they use it in aircraft manufacturing as well. So hopefully that answers your question.
Great. Another question. How does taking Eliquis and other meds for AFib affect the surgery and medication before or after?
Yeah, so we see a lot of this. I mean, AFib, you know, now that we all have smart watches and stuff, we're picking it up a lot more. And so people either have AFib, they don't have AFib, or they've been treated for AFib and had an ablation, and they're on these anticoagulants. And so we're able to do the surgery. We stop and start the medicines in a certain sequence, but it does not prohibit you from having the surgery. Again, you need to listen to your surgeon and their team on the timing of those medications. The medications work wonderfully, right? But you know, surgeons have to manage those medications because they do make the wound healing a little bit more complicated. So it's not a contraindication, but you need to talk to your surgeon and the anesthesia team on the timing of certain things when you would stop and start the medications. But it's something we see all the time. It's very common anymore, and it's not a disqualifier.
That's good to know. Daniel has a question. Can you jog again after hip replacement?
Yeah, you can jog. I tell people don't make that, we're trying to get you out of pain. I wouldn't tell you to, I mean, there are people that surf and jog and ski. I let them do everything. I don't know if I tell them to pick jogging as number one exercise. I would tell you, if you wanted to walk 10 miles, I'd give you a high five. If you want to jog, you can, but I don't know if I'd make it the go-to at that point. The reason is you want to keep this implant the rest of your life. You don't want to mess with it. And jogging is just a higher performance. But if your house is on fire, don't jog, sprint. Get out of there. So it's not like they fall apart, but you want to be wise. But I don't have any problems with somebody walking 10 miles a day, or pardon me, being on the elliptical, get on the bicycle, or swimming, skiing. I'll let them pretty much do everything. But doing jump rope every day after hip replacement, I don't know if I would tell them to do that. I think you need to watch some of the pounding if at all possible.
A question about steroid shots. So if I've had steroid shots, am I still able to have surgery?
Yeah, so the literature on corticosteroid shots, we used to do it all the time. In fact, when I was training, I did it all the time. But the literature coming out now, it's really showing some perhaps thought-provoking and changing of ideas. We now know, on hips, I really would reconsider that, and especially if you're female. The most recent studies show that your chance of having a hip fracture after a steroid shot of the hip is significantly higher. It's in both, it's higher, but it's really higher in a female. So I don't know if I would do that at a hip. In knees, there are still some people, and I have family doctors that do it, and even orthopedic surgeons that do it. You're on the sideline at least for 3 months if you've had a shot. You can have surgery, but in my hands, you need to wait at least 3 months. Some people are saying you should wait 9. Why? Because of the higher infection risk. We also know now with the current literature that if you get steroid shots, that it actually accelerates your arthritis. Well, we're trying to treat the arthritis, not accelerate it. So again, I think you got to look at it, be careful. We all want a quick fix. We want something that's easy. But sometimes what we've done in the past, now that you study it, may not be the best. So I guess buyer beware on that. It may have been what we've done, but it may not be the thing that's the best choice anymore. And it does disqualify you, higher infection rate. So I don't know if I would be very cautious into that, discuss that with your surgeon, but it does increase your infection rate in females and males, and increases your osteoporosis. The outcomes of people that have had steroid injections are inferior to people that haven't as well, that end up going to surgery. So you just got to be careful and talk those things over. Just don't knee-jerk reflex. Oh, I'm going to do that because it's easier and I need to get to this trip. Are you really making the best choice for your life long term?
Priscilla would like to know what materials are typically used for knee replacement.
I couldn't hear the question. Well, what materials are what?
What materials are used for knee replacement?
Knee replacement. So pretty much the same thing. They're titanium. Some of them have coatings. There are some ceramic ones that are coming out. That's a little bit too early to call because we haven't had 10 and 15 and 20-year results on the ceramics. They are coming out though. They all still have the same polyethylene, the plastic that's in between those. Most knee replacements are cemented, so they are cemented into place, and then they're titanium, chrome, cobalt, and then the plastic, again, the high density polyethylene is on the kneecap and on the tibia that cushions between the two surfaces.
We had some questions come in prior to the webinar starting, and there's, I noticed a duplicate question here from an attendee, but can both knees be replaced at the same time?
It's technologically possible, strongly discouraged. And again, so when you do that, it's not about convenience, right? This is not about convenience. It's about what's healthiest for you. And so if you look at the studies, there have been studies that have been reported on this. The people that have them both done simultaneously have higher complications, meaning that they go to the ICU, they're on ventilators, they have heart failure, and they have lung failure with more blood clots in their lung. There's no way we're going to opt for that. So even my dad, who'd had both of his done, is like, I'll try to do them both so I can guard sooner. I'm like, we're not trying to do this fast. We're trying to do it right. So I would strongly discourage that. Again, we're not trying to be convenient or fast. We're trying to avoid complications. And these are life-threatening complications. So can it technologically be done? Yeah. Would I advise it? No.
We have a few questions about physical therapy and exercises that can be done both pre-surgical and post-surgical. Can you talk on that a bit?
So on the front side of it, before surgery, you know, the term we'll use is prehab, right? Not rehab, prehab. Do as much as you can. Try to get, you know, if that helps you get your weight down to a better risk, then go ahead and do it. But riding the bike, getting in the pool, moving around, working on your balance, those are all things that are really, really important. So I think it's good if you can do it. Sometimes you start getting to the level where you get worse, right? You're doing so much work and you're already in stage arthritis that you start to hurt. Well, then that's not so good. So you got, each person's different. You got to balance it. But the general concept is the more you can do beforehand, the better. Afterwards, the key is get moving right off the bat. You know, so in the thousands of these that we've done outpatient, we have you walking, we have you going up and down the stairs within an hour and a half after surgery. You're doing stairs, so we don't baby you on purpose because those people do well. You should be in physical therapy. I think, and the studies have shown, going somewhere to physical therapy, get in a car, go to an outpatient place is much better than the opposite of that spectrum. Oh, I'll be in a nursing home, I'll sit around. It's not about convenience. What gives me the best result? Getting up, moving, going to the therapist, getting in the car, getting dressed, having an appointment is much better. Even them coming to your house is not as good. So again, I tell people it's not about your convenience. Oh, it'd be easy. I don't have to drive that day. You need to get up, get in the car, and go to therapy. And I don't care where. It's about getting the best results. So again, I think therapy should start as quick as you can within the, you know, in my hands, within hours after surgery, you're doing it, and then you continue that at home, and then under the guidance of a physical therapist, as soon as you can within the week in my hands.
We have a very specific question here. It says, please discuss the procedure done if the patient does not have a 90-degree bend 6 weeks post-surgery.
So I assume you're talking about a knee replacement at 6 weeks. So
Yes.
you'd need to talk to your surgeon about that. It depends on what you came in with, what your comorbidities were. Were you stiff before surgery? Do you have diabetes? Were you obese? What kind of component you have in there? Did you have previous surgery, previous infection? All those are there. But sometimes, you know, you may be alluding to a manipulation under anesthesia. Sometimes the therapist will talk about that. They really shouldn't talk about it because it's really a discussion the patient and family should have with the surgeon, because there's so many factors that are involved with that. So yeah, if you're right at 90 degrees or a little bit less at 6 weeks, you probably need to start talking about it. It may be as simple as just going to therapy more and working on it. Depends on how you've come and what your comorbidities are.
We've got a few more questions here. Is the
Sure.
incision smaller with the mini robotics for knee replacement?
So incision size, I get that all the time, you know, and incision size, don't let that fool you. Again, people will market that. The incision size for the robot can be small, right? But if I make a small incision, but I'm tugging so hard to quote unquote keep your incision small on the soft tissue, we've done you a disservice, and actually your result will be worse. So people are, how big's my incision? I go, it depends on how big of a knee you bring me and how big of a behind you bring me if we're doing hips, right? So those are more of the factors. You don't want to make unnecessary incision length, but it's better to have a little bit longer incision than to tug and pull on the tissue and hurt the tissue that you would never see. Those people don't have as good a results, and studies show that. But with the robots, we can be more accurate. We don't have to see quite as far. You do have pin site incisions, which you don't have with open surgery. So you get these little nicks with one stitch in them in there as well. Again, robot, no robot, smaller incision, bigger incision. You want to do what's right? And so do what your surgeon does best. Don't be sold on a marketing thing to try to get smaller incision thinking that's going to be the best outcome. It could give you a worse outcome. So make sure you do what's right. The tissue should be balanced. That's very important. However you get those tissues balanced, and you don't want to have, unnecessary tug with retractors just because you wanted a smaller incision. Now, I think skin and incision closure is really important. So doing that in the right way and using certain types of dressings, those are all beneficial and have been shown to decrease infections and increase the cosmetic look of the incision as well. So that's something that I think you can talk a little bit on marketing instead of just putting a bunch of staples in there. I think there are some studies that show that certain types of wound management can be beneficial for the patient.
How often is the nerve stimulator implant procedure used to help with pain?
So there's been a recent push in stimulators. They work well. There's no doubt about it. In some hands, some people are even using them pre-surgical, so they'll do them before surgery to try to help with pain afterwards. There are some people that get neuritis after surgery, and those, that's a small percentage, but those people really do hurt. And so I usually wait, anywhere between 4 and 6 weeks to see if that's calming down. We'll use some medications to help with that as well. But if it's not, then I'll get them to see a specialist, and then they can talk about doing blocks or putting in nerve stimulators. It's pretty rare, but for the people that have that subset of pain postoperatively, it does work fairly effectively. But there are some people that are even being more proactive, and I've done it, that will, in certain people with certain comorbidities, we'll put the stimulator in before surgery in an effort to keep everything calmed down through surgery and then their postoperative pain.
And there's a question here about recovery time. It does not specify knee or hip, but maybe if you can just talk about that a little bit, and traditionally how soon people can return to work after surgery.
Yeah, so it depends. It depends on the person, right? And their comorbidities. It depends on what kind of job you have, right? Being a telephone pole climbing utilities person is different than a desk job. But I'll just tell you my routine. I tell people it's an outpatient surgery. You're going to come in, you're going to have it done. You'll start off with a walker. You'll go home by lunchtime. You'll see me back in the office at 10 to 14 days. And at 10 to 14 days, you should have already transitioned off the walker and be to a cane. During that time, you're already seeing a physical therapist and walking and moving. So when I see you back at 10 to 14 days, not all, but a substantial set of my patients drive to that appointment. Say, hey, I drove today. I'm doing fine. I'm to a cane. I'm off my walker. I'm doing fine. I tell them to telework. This is more for office or sales type jobs, 6 weeks. However, at 3 weeks, most of our people are saying, I'm bored. I'm going to go golfing. I'm bored. We're going to take a trip. I'm bored. I'm just going into work, and I'm all okay with that. So again, the components are stable. The sooner you get back, the better you'll be. The more you sit at home and look at the wall, the worse you'll be. So there's a psychological component. You need to get back to your normal self. Oftentimes the family members are helpful in their thought, and they're like, oh, you're overdoing it, you're doing too much. And that's really a wrong statement. The best thing is, come on, let's walk. I'll walk with you again. Oh, you're tired, rest. Let's go walk after you get your rest. So the recovery is a lot quicker than it used to be. And the reason is because those people do so much better.
All right, we have 3 final questions. The first is, what can you say about complications like infection, blood clot, dislocation? Can you share percentages or just ways to avoid complications?
Yeah, so the biggest thing you do to avoid complications is to prevent them before they happen, right? So that's why we don't have steroid shots. We make sure your diabetes under control, glycemic control is important. Make sure your obesity, stop smoking, that type of stuff. Prior to surgery, we give you special soaps, we use special antibiotics, we use special preps, things that last a long time. We even clean your nose, believe it or not, before surgery. Those are the things that we do. You're talking well below less than 0.5% on infections. For blood clots, we get you up walking immediately. We try to use the blocks. The blocks themselves decrease the chance of blood clot. We put special things on your legs. We start you on aspirin. All those things are very impactful, and we've studied them. So you just got to talk to your surgeon and figure out what they're doing. There should be a plan in each one of those. It's not just happenstance and we do it one way this day and another day. Everything is there for a reason and impacts your outcome. and to try to avoid complications. But the biggest thing is just talk to your surgeon and just follow their instructions. Don't be trying to overthink it. If they say get up and walk, get up and walk. If they say take these medicines, take these medicines. So you can ask them about them, but don't try to overthink it. There's years and decades of experience trying to get these things refined, and we're really quite good at getting these to where we need to be.
Along those same lines, the question is, do you cut any veins or arteries? If not, what can cause the risk of blood clotting?
I guess I don't know. The idea is we don't want to cut any veins or arteries. We want to keep those alive and well. I don't the blood loss, if that's, and I may be reading into this question, but we don't want to cut any arteries or veins. We do not, period, ever. But you do, what is the risk of bleeding no matter what you're doing, whether it's a hip or knee? And it's usually from the bone, is, because you do have to make some small cuts on the bone, 4 to 8 millimeters. I was showing with the T-Mini, the robot there, and the bone will ooze. It doesn't bleed, it doesn't pump, it just kind of oozes if you look at it. But we've really solved that problem pretty well by using the trans-ischemic acid and having low blood pressure during anesthesia. So that's really not an issue anymore, but we certainly don't want to cut any vessels.
And the final question of the night, since both knees cannot be done at the same time, how long do you wait between surgeries?
Yeah, in my hands, I just decline people. It's not worth their health to try to do them simultaneously. Although you may find, Aunt Pearl or somebody across town that does them. I just don't think it's worth the risk for somebody's health. So in my hands, I make sure they've recovered enough, and I'll do the second one at 6 weeks. I'll wait 6 years, whatever they want to do, but 6 weeks is kind of my threshold, and that's usually when they're pretty independent on that other leg and like, yeah, I'm ready to go. But you can wait as long as you want, but I at least try to wait around 6 weeks on that.
Great. Do you have any final thoughts you'd like to share?
No, I mean, just, talk to your surgeon, find out what the options are. It's all pretty researched anymore. It's not just, well, we'll try it this way. There's a lot of research out there. You want to do what's best. Try to keep the emotion out of there. Talk to your, get the facts. You're not too young, you're not too old. It's about quality of life. Those are the things that you look at in doing this. You can really mitigate the complications by doing things on the front end, and that's why you talk to your surgeons about what you do to mitigate the chance of complication. And then your outcomes are really optimized at that point. Look at the facts. Try not to get sold on anything that's marketing. Again, you just really need to have confidence and have a good relationship with your surgical team.
Great. Well, we would like to thank all of you for participating in tonight's webinar. Our next webinar will be held on April 8th. Dr. Michael Canone will speak on if you have been told you have arthritis, what now? Enjoy the rest of your evening. Thank you again, and good night, everyone.
Thank you all.